Hello friends, so today we have gathered to discuss an operative case of open Baker cyst excision. But before we go to OT, we need to understand certain salient concepts, certain salient management protocol before going to the OT of open Baker cyst excision, which is also known as the popliteal cyst. So without further ado, let us begin. Let us begin with our today's plans. What are planned for today's? First of all, we are going to understand the basic concept of Baker cyst. Then we are going to understand the management protocol in day-to-day clinical practice, and at the end we are to go to at the end we are going to go to the OT of a persistent large Baker cyst in a young female. Okay, so without further ado, let us begin first with the basics. Okay, let us begin first with the basics. So what basically is a Baker cyst? What basically is a Baker cyst? So it is primarily, mark my words, it is primarily an intra-articular pathology manifesting extra-articular. Most commonly we can get it mistaken. It is not an extra-articular pathology, it is an intra-articular pathology. The primary cause is intra-articular, it is not extra-articular. It is an orthopedician's business. Okay, so the primary intra-articular pathology, which is usually osteoarthritis, meniscal injury, or inflammatory arthritis. Most common in clinical practice, we come across some meniscal injury which gradually progresses to some swelling in the popliteal region, which gradually becomes painful, and patient comes to us multiple times in the OPD, and that is when we should understand this concept. So primary intra-articular pathology is there always inside the knee. Okay, due to which the intra-articular synovial fluid pressure increases. Okay, due to which the fluid tracks posteriorly into gastrocnemius and between say gastrocnemius and semimembranosus bursa. We are going to understand this clinically along with that figuratively all together in this video. Okay, okay, so this mechanism is a one-way valve mechanism forming the cyst. Okay, so this is the articular border. Okay, whenever there is some meniscal injury or intraarticular pathology, the bursa between gastrocnemius and semimembranosus, out bulges, herniates outside, and it forms a cyst which is a one-way pathology, one-way valve mechanism, which forms a cyst at the posterior popliteal crease. Okay, so that is the basic concept of what actually Baker cyst is. Okay, what actually Baker cyst is. Okay, now without further ado, let us understand the management protocol. Okay, first thing is you need to go for proper clinical examination of the cyst, proper palpation, multiple test positive, fluctuation, sometimes trans illumination. All why it is important? Because the cyst fluid is synovial fluid. It is the extension of the intraarticular fluid. So it is the synovial fluid of the joint. Am I making sense? It is the synovial fluid of the joint. Okay, so clinical examination is important. We need to understand the boundaries, anatomical landmarks, which you are going to discuss in the operative tutorial. Then second is you need to go for the ultrasonography. Multiple reasons to confirm the Baker cyst, to know the size, whether there are any septation or any other pathology you are suspecting, and most importantly, when your plan is to aspirate, so you go for USG guided aspiration. Okay, and any day MRI is the best investigation, gold standard investigation to understand the size, anatomical location of the Baker cyst, when you are, most importantly, when you are planning an open excision. Okay, so that was the basic concept. Now management, most important for management is to address the joint first. The primary pathology needs to be addressed. Am I making sense? Okay, so treat the primary pathology first. Okay, so whatever is the reason, osteoarthritis, meniscal injury, or inflammatory arthritis, you need to manage that first. We are going to discuss. Okay, and for the cyst, the compressive symptoms and all, you can give a trial of conservative management 4 to 6 weeks, the rice therapy and NSAIDs and routine and anti-inflammatory management. and wait and watch for 4 to 6 weeks. Okay, now if at all it doesn't get resolved, what are the management protocols? First is you can go for USG guided aspiration, but personally saying is only a short term solution. Why it is a short term solution? Because we are not correcting the pathology. The intra-articular synovial fluid pressure is more, it is continuously draining over here. You aspirate it once, it will again recur. The chances of recurrence are very high. Some go for USG guided respiration along with the corticosteroid injection. Okay, but all these are short term solutions. Let's suppose the patient is not willing for operative excision, it is a small cyst, multiple reasons for not going for operative management, then you can go for USG guided aspiration. That also USG guided is very important, no blind procedure, because you are endangering the popliteal plexus if at all you are going blind. Okay, then you can also go for arthroscopic management for small cysts. Okay, so in same sitting you can go for arthroscopic repair. Let's suppose there is meniscal tear, you can go for arthroscopic meniscal repair, along with that the excision of the small cyst. Now we are here to discuss the open excision. So when do we go for open excision? When there are persistent or recurrent cysts, large cyst, mass effect cyst, neurovascular compression, all these symptoms, and then whenever, most importantly, whenever there is it is a recurrent, persistent, then such aspiration and conservative management doesn't help. You have to go for operative excision, and what you need to take care in operative excision, that is what we are going to discuss in the operative tutorial. Okay, so this is the operative tutorial. First is you need to correct the intra-articular pathology first. So definitely it is always a good idea to go for diagnostic arthroscopy before going for open excision, and as well as meniscectomy or meniscal repair, whatever you find in diagnostic arthroscopy, which should be followed by open excision. Okay, so our case which we are going to discuss today, the operative case for which we have gathered here, she is a 35 years old lady. She has she has complained over the popliteal region, large swelling, massive swelling, since last which has gradually progressed since last 6 to 9 months. Okay, we got the MRI done. It was a large cyst measuring 81 by 34 by 28 which had last mass effect and compressive symptoms, and restricted range of motion and persistent pain. So she had mass effect, extremely painful knee range of motion, and the long course of the cyst. Okay, so what are the operative steps? This is the crux. These few slides are the crux, following which we will be directly going to the OR to discuss the operative case. Okay, so what are the operative steps? First, let us understand the anatomy. Okay, so this is the medial part, this is the lateral part, this is the proximal, and this is the distal. Okay, so medially, this part is the popliteal region. Okay, so proximally are the hamstring semimembranosus. Okay, so these are the hamstring semimembranosus, semitendinosus on the medial aspect. Laterally there is biceps. Okay, going distally, this is the medial head of gastrocnemius, this is the lateral head of gastrocnemius. And the most important part which we are worried of is the popliteal plexus. This part is the popliteal plexus. Okay, and on the middle there is medial sural cutaneous nerve, which can act as a landmark or intraoperative guide for the location. Okay, now the baker cyst is usually most commonly located between the medial head of gastrocnemius and the semitendinosus, the hamstring muscle. So this is the most common location of the baker cyst, and this is the usual extent from medial head of gastrocnemius towards the hamstring. Okay, now we will discuss the operative tutorial, we will discuss the operative steps. Okay, the first thing first, we put the patient in prone position. Now what we need to begin about? Tourniquet, definitely required tourniquet. And So how is our incision? How is our incision? Okay, so let's suppose this is the Baker cyst. This is the usual location of the Baker cyst between medial head of gastrocnemius and hamstrings. Okay, so our incision has to be centering over the Baker cyst, centering over the Baker cyst, roughly around at the medial head of gastrocnemius. Okay, so this is the extent of incision when you want to go for a mini open Baker cyst dissection. Okay, if you want to extend it, if there is a need of larger exposure in massive cyst, in the case which we are going to discuss, you can extend the incision going over the popliteal crease. But make sure, mind you, whenever you are crossing the midline laterally, you are going to encounter the popliteal plexus. So make sure this it is one of those OTs where we go exactly to the place we stay away from in our usual intraoperative practice. Okay, so you have to be careful. This is your incision. Okay, if needed you can go laterally over the popliteal crease. Okay, so as soon as you put the skin incision, very important to go slow, very important to do careful fine dissection. After you pass the skin, you come across the retinaculum. Over here. So you have to incise the retinaculum. As soon as you incise the retinaculum is when you will find the Baker cyst. And after delineating properly using careful fine dissection, you will identify the medial head of gastrocnemius, you will identify the hamstring and the Baker cyst lying between these two muscles. Okay, so first is skin, followed by retinaculum incision, and then gradual delineation of the cyst to find the anatomical landmarks, the medial head of gastrocnemius, hamstrings, and most importantly, stay away from the popliteal plexus. You need to be very mindful. As I said, this is one of those OTs where you go exactly to the place you avoid going to in your routine operative practice. Okay, so first is skin, retinaculum, gradual dissection, and then you delineate the cyst. Then you delineate the cyst. Now once you have identified the cyst, okay, then you need to identify the proximal lateral border. You need to identify the proximal lateral border of the cyst. Gradual careful dissection, identify the proximal lateral border, following which you start dissecting distally and medially. Why distal and medially? Because this is the safe zone. Carefully find the proximal lateral border and proceed your dissection or delineation of the cyst going distally and medially. Okay, so this is where the base into the intra-articular extension lies. Okay, so once you have dissected from proximal lateral border, which is close to the popliteal plexus, where you need to be careful about, then you go distal in medially. And once the cyst is isolated, you find what do you do? Let's suppose this is the articular margin and this is the Baker cyst. Okay, so you need to identify this point. This is the opening into the joint. This is joint and this is the Baker cyst. Okay, so careful dissection, you need to identify this point where it opens into the joint. And what do you do? If at all the cyst is very large, in the case we are going to discuss operative, it was very large. Okay, so sometimes if at all necessary, you can aspirate the Baker cyst also to know the anatomy where it is extending. And in toto excision of the Baker cyst is must. Okay, so once you identified this part, you find the base. After finding the base, you clamp artery over here, and you have to pass per string suture at the base. Okay, what is important, you have to I can't emphasize it enough because it is very important. Okay, it is very important. Let's suppose this is articular margin. Okay, this is the articular margin, and this is the Baker cyst. Okay, so this part you have to make sure you pass the purse string suture over here, and then you go for the resection of the Baker cyst. Why it is important? If you don't, if you go for incomplete removal of the Baker cyst, you are 100% giving the chance of recurrence of Baker cyst. But once you have secured the opening into the joint, there are very less chances of recurrence, and most important is to remove the Baker cyst in toto. After removal of the Baker cyst and securing the opening, after removal of the Baker cyst and securing the opening, check for any residual Baker cyst tissue in the popliteal fossa. Okay, after the resection, after securing the opening, you go for copious wash, following which most important is to close the retinaculum again. Most important is to close the retinaculum again, which prevents the herniation further. Okay, so I repeat: skin incision centering over the Baker cyst, near about at the medial head of gastrocnemius, extending proximally. If at all required, cross the popliteal crease. Be very careful when you are crossing the midline. Very extremely careful when you are crossing the midline going laterally, because you are encountering the popliteal plexus. Okay. Gradual dissection. Identify the proximal lateral border. Go distally and medially towards the medial head of gastrocnemius. Identify the opening, secure the opening into the joint with sutures, resect the Baker cyst, make sure it is in toto resection, check for any residual Baker cyst tissue, and then retinaculum repair followed by routine closure. And post operative protocol, it is important to keep the knee in extension for at least 10 days. Why? Because the crease over here, the popliteal crease, the skin have very high chances of maceration, so you need to protect it from maceration. Keep it in long knee brace or in extension. So today's operative case is a 35 years old lady who presented to us with a painful posterior knee swelling, gradually progressed since last 6 to 8 months, restricting her range of motion and activities of daily living. We evaluated the lady with MRI scan and USG, which showed a massive large Baker cyst 8 by 3 by 3 centimeters extending from medial head of gastrocnemius to the hamstrings, located over the medial aspect, which is the anatomical. So here location. Is a case of young lady who is having a large Baker cyst over the popliteal area. His primary pathology was always intra-articular. So she had a partial ACL tear, due to which the intra-articular extension has come out to form the Baker cyst. Usually Baker cyst is between medial head of gastrocnemius and the semimembranosus, semitendinosus. Okay, so we have taken this incision. This you can see is the Baker cyst. This is the retinaculum. We'll progress further. Okay, so we have isolated the Baker cyst with careful dissection. The location is most common and anatomical, exactly between the medial head of gastrocnemius and semimembranosus, semitendinosus. So we'll identify the proximal lateral border, and we'll be going distally and medially towards the safe zone. This is the popliteal plexus where we need to be careful about. Now we'll remove the cyst and we'll get back. So this is the classical location: medial head of gastrocnemius, semimembranosus, semitendinosus, and the cyst is just slightly ruptured, and we can see the synovial fluid which is coming out. Okay, so we dissected the Baker cyst from the proximal lateral border going distally towards the safe zone. Okay, now we have removed the we have isolated the Baker cyst. This is the base of the Baker cyst going intra-articular. Okay, so we will put a purse string suture at the base after cutting the Baker cyst. The Baker cyst is punctured. It was ideally from here. Previously it was from here to here, but once it has punctured, so gradually it becomes small, and this is just the wall which is there. Now we'll apply the purse string suture at the base, and we'll close the retinaculum, most importantly to prevent the herniation again, and then routine closure. Thank you. So team was myself, Dr. Mihir, Dr. As, Kalpesh brother. Yes. So this is the resected Baker cyst with the wall made of synovial tissue and fibrous tissue. I hope you found this tutorial useful. This was Dr. Mihir Tejura signing off with Baker cyst operative tutorial simplified for you. Stay tuned for more such operative tutorials, interesting theoretical concepts and practical case presentation tutorials. to Bones Orthopedics Simplified for you by Dr. Mihir Tejura. Thank you so much, guys.